Hi, my name is Amanda Beers, and this is my Capstone Project. I will be presenting information regarding borderline personality disorder, including its definition with symptoms and features, comorbid disorders, diagnostic criteria, therapeutic interventions and medications, and I will conclude with a summary. What is borderline personality disorder? Borderline personality disorder, or BPD, is a pervasive pattern of instability in affect regulation, impulse control, interpersonal relationships, and self-image. In many ways, the borderline syndrome has been to psychiatry what the virus is to general medicine, an inexact term for a vague but pernicious illness that is frustrating to treat, difficult to define, and impossible for the doctor to explain adequately to his patient. BPD is a disorder that appears similar to many other disorders and is often difficult to recognize. Only recently, in the 1980s, was BPD even documented as an official diagnosis in the DSM. Those who grow up to become borderline will often have a troubled childhood marked by trauma, chaos, and abuse, making it impossible for proper coping skills and emotional stability to develop. After learning what BPD is, we move to the symptoms. There are several symptoms displayed by borderlines with varying degrees of each. The most common and defining symptoms of BPD are instability, impulsivity, destructive behaviors such as promiscuity, drug and alcohol use, and self-injury, difficult interpersonal relationships, and suicide. Continuing with further explanation of the symptoms, the first and most defining symptom or feature is instability, specifically emotional instability. Borderlines are recognized as unstable due to their often chaotic actions. Instability also provokes the other features of BPD. Everyone, including the borderline, is in a constant state of confusion as to how the borderline will respond to any given situation. The disorder is designed to keep everyone guessing as to what will happen next. Instability leads to impulsivity because the borderline is not clearly thinking through her actions or emotions. With impulsivity, the borderline wants what she wants when she wants it and will not let anyone or anything stand in her way to get to it. There is no plan of action, no thought or reasoning behind anything she does. She simply acts on impulse. There is no appearance of self-control, just the incessant, impulsive need to self-medicate and alleviate the want. Next, we look at the destructive behaviors of borderline personality disorder. Instability and impulsivity escalate destructive behaviors, causing the borderline self-image to deflate. The more common destructive behaviors include promiscuity, drug and alcohol use, and self-injury. Promiscuity increases trouble in already tumultuous relationships and increases risks of sexually transmitted diseases, rape, and other abuse. Drug and alcohol use is a way of self-medicating. It frees the borderline from her chaos, and the constant need to feel free fuels the need for more substance abuse. Self-injury is often a coping mechanism and is also a form of self-punishment for the person the borderline thinks she has become. It is defined as a deliberate destruction of one's own body tissue in the absence of intent to die. Self-injury is also one of the criteria that leads to a diagnosis of BPD. The difficult interpersonal relationships, another feature of BPD, are one of the outward displays of the struggles within. The relationships of a borderline are often misguided due to the distorted images she holds for others. The image distortions are defense mechanisms, and the most prevalent to BPD is splitting. Splitting means the borderline views a person, the world, or even herself in black and white. These things are either all good or all bad, but there is no middle ground. The borderline is unwilling and unable to recognize that another person can be good and do bad things, or vice versa. The last symptom of BPD to be discussed is suicide. Unfortunately, suicide and BPD go hand in hand. In borderlines, the suicide rate is in excess of 50 times that of the general population. What is worse is that after one attempt, the likelihood of more suicide attempts increases. Not all suicide is a wish for death. It can sometimes be a cry for help. However, in any suicide attempt, whether attention seeking, a cry for help, or a real attempt to die, should be taken seriously and must be addressed immediately with a mental health professional. There are 9 criteria for BPD, of which 5 out of those 9 must be met to give the diagnosis of BPD. Frantic efforts to avoid real or imagined abandonment, unstable and intense interpersonal relationships, lack of clear sense of identity, impulsiveness in potentially self-damaging behaviors such as substance abuse, sex, shoplifting, reckless driving, or binge eating, reoccurrent suicidal threats or gestures, or self-mutilating behaviors, severe mood shifts and extreme reactivity to situational stresses, chronic feelings of emptiness, frequent and inappropriate displays of anger, and transient stress-related feelings of unreality or paranoia. There are several comorbid disorders that can occur with BPD. This includes both Axis 1 and Axis 2 disorders. The most frequently comorbid disorders from Axis 1 are anxiety disorders, mood disorders, bipolar disorder, ADHD and ADD, and eating disorders. Axis 2 contains all personality disorders, and while it is less common for a person to have 2 personality disorders, it is possible. We now shift to the therapeutic interventions for BPD. The most well-known is dialectical behavior therapy, or DBT. DBT focuses on the opposing views the borderline has, called dialectics, and works to correct them. The next therapy is systems training for emotional predictability and problem solving, called STEPS. This therapy focuses on educating the borderline about her disorder and gives emotion and behavior skills training. The next, though less frequently used therapy for BPD is schema-focused therapy, or SFT. A schema is a perception. SFT works to correct maladaptive schemas or perceptions created early in the borderline's life. The next 2 approaches are psychodynamic approaches. The first is mentalization-based therapy, which changes the thought processes of the borderline's mind, and transference-based therapy, which focuses on the distortions the borderline has created. Medications are used for symptom management of BPD. The most commonly used medications are antidepressants, mood stabilizers, neuroleptics or antipsychotics, and anti-anxiety meds. All of these medications work in different ways to level out erratic emotions and calm the chaos of the borderline's mind, making therapeutic interventions more effective. Some medications may need to be used throughout the borderline's lifetime. Others may only need to be used on a temporary basis. Throughout this presentation, you have learned about the definition of BPD along with its symptoms and its features. You have learned about the comorbid disorders, diagnostic criteria, and therapeutic interventions and medication used to treat BPD. I hope this PowerPoint was informative, and I thank you for taking the time to learn about borderline personality disorder.